I think there's an obligatory meeting today that was running concurrently with the grand rounds. I just saw someone who had to go to a meeting at 6:45. Do you know anything about that?
I thought there was at least 2 conflicts I had, but I was...
What a shame. Let me just give it another 3 or 4 minutes, and then we'll get started.
Hey, thank you for coming. Really appreciate it. Thank you. And thank you for all the patients that you have been referring to me. I will keep your data when I see them. I will. So one of you, I know, but was your partner, it's a lady here with Torsats.
Yeah.
Good morning, everyone. It appears that there's a conflicting meeting about surgical timeout at the same time we're having this meeting, but the subject is so interesting. It's worthwhile, of course, going through with it. I remember early on when electrophysiology was a cardiologist interpreting an EKG. That has morphed into that and transcatheter ablation, device usage, and so forth. So this is a full-fledged subspecialty in itself. Many of us know, at least in the adult congenital heart sphere, arrhythmias causing sudden death are the major cause of demise. And of course, in the older population, atrial fibrillation has vexed those older citizens who have significant problems with this, and heart failure and so forth. So it's fitting and proper that we should have an excellent review on this subject, which will be performed by Dr. Cesar Bonilla, who's relatively new to our service, but not relatively new to the area. He had his early training in Colombia, and then had his residency at the Cleveland Clinic, Florida, and in Jacksonville. So I, for one, am very much interested in this topic, having done arrhythmia surgery for many, many years and followed it from the inception of Wolf Parkinson White at Duke University on to the ablation procedures for that same Wolf Parkinson White, atrial reentry tachycardia, AV nodal reentry tachycardia, focal tachycardia, and so on and so forth. So it's with great pleasure to introduce Dr. Cesar Bonilla to listen to his talk about trends in electrophysiology. Dr. Bonilla.
Well, good morning, everyone. I have to say thank you for being here this morning. It is for me a great opportunity to share with you some of the inputs I have over the recently released data regarding management of patients with different cardiac conditions in the electrophysiology field. So I don't have significant financial disclosures. We will go over atrial fibrillation mostly today. We will discuss some interesting trials that have been released or published over the last few months, most of them this year, I will briefly talk about cardiac resynchronization therapy and what is new in this topic. And finally, some remarks about his bundled pacing and how can we apply it. This not new, but improved technology over the last few years. So we will start with the atrial fibrillation. And I want to say and make emphasis first that it's not a benign condition that we all know, but sometimes we forget about it. It is not benign. It has been associated with increased mortality, as I'm going to show in the next slides. And it's not benign because it is a progressive disease. So in patients that have already established with atrial fibrillation, it will happen certain changes in the hemodynamics, in the physiology, and the morphology of the left atrium, but also in the left ventricle. Some patients will develop over years significant diastolic dysfunction due to the enlargement and fibrosis of the left atrium caused by the toxicity that atrial fibrillation itself causes in the cells. But also remodeling of the left ventricle. Some people will develop, again, diastolic dysfunction or LV systolic dysfunction, and not necessarily mediated because tachycardia, just because the atrial fibrillation, even if it's rate control, can cause all this. And that is true even for the asymptomatic patients, or what we say quoted asymptomatic patients. Sometimes we don't really search for those symptoms as they can develop slowly through the years. And on the other hand, an asymptomatic patient today, it may not be asymptomatic in 10 years, but in 10 years it will be more difficult to treat. So those are the things I want to remind and keep in mind when we see patients with atrial fibrillation. So from the Framingham data, this is a publication from Circulation in 1998 from the cohort of patients with atrial fibrillation in the Framingham study. Clearly, atrial fibrillation was associated with a 1.5 to 2 times increase in mortality. And that it was when it was adjusted to other comorbidities, including cardiovascular conditions. So it's an independent risk factor for mortality itself. As we can see, that is true across the ages. So this is a slide with the Kaplan-Meier curve for patients with age between 55 and 74 years old. And we can see that it is a significant increase in mortality for patients in both genders, men and women, when it's adjusted for cardiovascular condition. This is for the older population. And we can appreciate that during this study, the curves separate very quickly from the onset of the evaluation. With that in mind, soon after this publication in 1998, there was an important trial that was conducted. It was the AFFIRM trial, and it was with the aim of comparing basically antiarrhythmic drug therapy versus rate control. Antiarrhythmic drug therapy trying to maintain sinus rhythm. So there were more than 4,000 patients that were enrolled in this study with atrial fibrillation. The primary endpoint was overall mortality, and secondary endpoints death, disabling stroke, and access encephalopathy, major bleeding, and cardiac arrest. The results of this study were quite disappointing. In terms of mortality, there was no difference when you compare patients that were treated with antiarrhythmic drug therapy with the aim or the hope to maintain sinus rhythm versus patients with medical management and rate control. And this is the pseudo-analysis with all the variables. And actually, rate control strategy had the tendency to do better in this study than antiarrhythmic drug therapy, except for the younger patients. Now, the caveat in this study, there was a lot of crossover. So in the arm with patients with antiarrhythmic drug therapy, antiarrhythmic drug therapy basically was not effective to maintain sinus rhythm in many of those patients. So the most common used medication was amiodarone, associated with a lot of side effects, so it had to be discontinued. And other drugs were a lot less effective. So in reality, it was more than 40% of the patients that were studied in the rhythm control arm didn't maintain sinus rhythm. So that's one of the things. And on the other side, many of the patients that were in the rate control strategy have a spontaneous conversion to sinus rhythm. So there was a lot of overlapping and crossover. As a result of that, there was no difference in terms of mortality. That was the primary endpoint. Now, when we analyze patients that really maintain sinus rhythm, so the maintenance of sinus rhythm, it was associated with a mortality benefit. So maintaining sinus rhythm is beneficial. Nevertheless, the same analysis say that the use of antiarrhythmic was associated with increased mortality. So antiarrhythmic therapy itself is not probably the best option to treat a patient with atrial fibrillation, based on the results of the AFFIRM trial, which is the largest trial that we had done for evaluation of patients with atrial fibrillation. The associated increased mortality in patients with antiarrhythmic drug therapy may be in part due to higher indices of pulmonary embolism and stroke due to the discontinuation of warfarin. That was the anticoagulation therapy in that study. The last probably couple of years, I think 2016, this is 2014, the CAMTAF trial. It was a small single-center study that was conducted to evaluate catheter ablation versus medical therapy, either antiarrhythmic drug therapy or just beta blockers or rate control strategy for patients with heart failure and atrial fibrillation. So the primary endpoint was improvement on left ventricular ejection fraction, and secondary endpoints of this study was reduction in LV volume, so basically LV remodeling, VO2 consumption, BNP, and then some New York Heart Association functional class and some scores in terms that measures the quality of life and symptoms, basically. So the result of this is, this is the design of the study. They enrolled around 390 patients, which from those 55 were eligible for the study, and they were randomized in two groups. For one arm for catheter ablation, the other arm for medical management. It was a smaller study, around 48 patients, and they were followed up for 6 and 12 months. These are the demographics. It was a very well-balanced study in terms of characteristics. The mean EF was around 32% in both groups, with a moderate size left atrial size. The patients were relatively young, so 55 and 60 as a mean age. This is an important consideration in terms of how can we apply this data into our management. There were different types of atrial fibrillation, and most of them they were persistent, and some of them they were long-standing persistent. This is a busy slide, but when we go over the slides, and we can see that in all the primary and secondary endpoints, there was a benefit in catheter ablation. So catheter ablation was effective in maintaining sinus rhythm first, and secondly, in decreasing LV volumes, and all the secondary endpoints we mentioned before, including the quality of life and BNP measurement, VO2, et cetera. So this was an encouraging findings. So later on, there was an outcome trial that was published this year in New England Journal, the CASTLE AF. This study compared catheter ablation and medical therapy for the management of AFib patients with heart failure as well. So the primary outcomes are composite of all cause of death or worsening heart failure. And the secondary outcomes were all cause of mortality, cardiovascular death, stroke, hospitalization for heart failure, hospitalization for cardiovascular complications, and stroke. I don't know if you can read well here, but there was a large study, and they initially enrolled around more than 3,000 patients. After evaluating the patient for exclusions criteria, et cetera, there were more than 300 patients that were randomized for either catheter ablation or medical management in the study. So these are the baseline characteristics. It was a well-balanced study. Relatively young patients as well. Median age was in the 60s. Older patient was around 74, 71, 74 years old. And the majority of patients was also, they were male. So it's around 80% were male. There was a small representation of females in this group. There were a significant number of patients, of course, with heart failure. All of them would have heart failure, and the mean ejection fraction was around 30% in both groups. So different type of atrial fibrillation as well, paroxysmal, persistent, and long-standing persistent. So in the primary outcomes, death or hospitalization for worsening heart failure was a significant reduction in the primary outcomes in the catheter ablation arm versus the medical therapy. It was around almost 40% reduction in this combined outcome, which is actually very impressive. When we look at strategies for decreasing mortality in patients with heart failure, we had to go back to early 2000 when we developed the ICDs and the defibrillators, basically, and cardiac resynchronization therapy. So this is actually very encouraging and it's a powerful result in terms of heart failure management. As a secondary outcomes from death from any cause, significantly decreasing mortality as well, around 40-something%. To me, those are very powerful results. So it's, of course, we're talking not absolute reduction, but relative risk reduction. And with the caveat that those are patients enrolled in a study and ultimately managed. So those are patients we have all of them have defibrillators, all of them either defibrillators or cardiac resynchronization devices, and ultimate medical management with all the medication that we know that have improved mortality. So this is an addition to ultimate medical therapy. Hospitalization for worsening heart failure as well, significant reduction in these events. And when we look at the subgroup analysis, we see that it's true for most of the variables, with more modest results for female and elderly patients, as well for patients with a significant cardiomyopathy. So when the EF is less than 25%, nevertheless, it was all across the variables and subgroup analysis, there was a benefit of catheter ablation over medical therapy. I had to mention that in this study, many of those patients have persistent atrial fibrillation, so or I would say majority of them. So this is, I think the result of this study may change the way we see patients with heart failure and atrial fibrillation. Then later this year it's not yet published, but it was released in the Heart Rhythm Society meeting and have been presented by Dr. Packer from Mayo Clinic in different events, and it's the CABANA trial. So the CABANA trial, after the AFFIRM trial, is probably the largest study have been done in patients with atrial fibrillation. It compared catheter ablation versus drug therapy for the treatment of new onset or undertreated atrial fibrillation. The primary outcome was all-cause mortality, disabling stroke, serious bleeding, or death. The major secondary endpoints are death of all cause or cardiovascular hospitalization. So the study designed, the enrolling of the patients with new onset or undertreated paroxysmal, persistent, or long-standing atrial fibrillation who were in carotid. That was at the discretion of the physicians that were enrolling the study. So inclusion criteria, so they were greater than 65 years old, or if they were younger, they would have one or at least one cardiovascular risk factor for a stroke. One risk factor for either a stroke or cardiovascular outcomes. And they were eligible for ablation, means they didn't have any contraindication. They have more two rhythm or rate control drugs have been used. And exclusion criteria for this study, basically any patient that have prior valvular disease with surgery, prior ablations, or they have any contraindications for anticoagulation. Those are the major exclusion criteria. So they were randomized in 2 big groups, more than 1,000 patients in each one. The primary ablation was done pulmonary vein isolation. And then if the patient requires, to the discretion of the operator, linear ablation, CAFE, or anything, all those patients needed to be anticoagulated. Drug therapy were basically rate control or antiarrhythmics. So it would be accepted either way. So as I mentioned, there were more than 2,000 patients enrolled in the study. They were very well balanced, as I'm going to show later. So from all these patients, over 1,000 patients have ablated ablation, and some of them they have repeated ablation, around 20%, and medical management, all of them, basically. At the end of the follow-up, it was close to 1,000 patients in each arm, and these are the demographics. So the median age in the 60s. Same thing, relatively young patient. And I say relatively young patient because I perform ablation in patients over 80 years old. Not frequently, but we do that. So females, there were minority to them. They were, BMI of about 30%, which is also an important data in terms of some, when we look about the risk of catheter ablation, you see, elderly female with low weight. So those are the things that we analyze when we try to incorporate the data into the management of the patients. These are very well balanced in terms of risk factors, sleep apnea, cardiomyopathy, congestive heart failure, and New York Heart Association functional class, or prior stroke. This is, most of the patients have paroxysmal atrial fibrillation or persistent. However, it's a good number of patients with long-standing persistent, around 10% in each group. And the median, this is the other thing. So you see the year since onset of AFib, it was around 1 year. So they were probably not a lot of patients with long-standing atrial fibrillation, which is, I would say, more than a year, more than 5 years sometimes. Severity of atrial fibrillation, this is all across the board. So when we do an analysis of intention to treat analysis in this study, there was no difference in the primary outcome. So I'm going to clarify that. Intention to treat analysis means it's a group of patients that are randomized for catheter ablation and a group of patients randomized for medical management in this particular study. So when we analyze as an intention to treat, we assume that all those patients effectively underwent catheter ablation, which not all of them did. There was a small percentage of patients didn't have ablation. And we assume that all of them remain in sinus rhythm. So those are the analysis with intention to treat analysis. So with that regard, the primary endpoint was not met. The same thing for all-cause mortality risk. However, the secondary outcome, when we look at the death or hospitalization, so there was a significant reduction in the catheter ablation group. And this is the SUT analysis in all different variables. As I mentioned before, this study, at first glance, we looked, there was a negative study for catheter ablation. Same thing here. Now, the study showed that catheter ablation was superior to drug therapy in maintaining sinus rhythm. Now, when we look, we analyze the data as treated analysis. It means we were successfully treating patients with atrial fibrillation with catheter ablation. Those patients maintain sinus rhythm. The primary outcome, which is all-cause mortality, was significantly reduced with around almost 40%, around 30% reduction in this in mortality and death or cardiovascular hospitalization. So This is also very encouraging. So as I mentioned before, there are not too many interventions that we have identified to reduce mortality in patients with heart failure. So this is one of them. This is the slide I mentioned before. Can adverse events, significant number of, this is the number of adverse events that there were actually adverse events related to the procedure itself. They were minimal, less than 1% overall. And this slide, these are the points I want you guys to take home. The first, atrial fibrillation is a very complex arrhythmia. It's independently associated with an increased risk of death or major cardiovascular events. Catheter ablation is, with no doubt, superior to antiarrhythmic drug therapy in maintaining sinus rhythm. And it can reduce the risk of death and other major cardiovascular events, especially in younger patients, in patients that don't have long-standing persistent atrial fibrillation, and patients with heart failure. The benefit of catheter ablation is higher in younger patients, as I mentioned, and that we should have continuous effort to improve the efficacy and the safety of the procedure, to extend the benefit to older patients and patients with long-standing atrial fibrillation. Is there any question, or we will prefer to have the question at the end of the conversation? Okay. So now we're going to talk briefly about cardiac resynchronization therapy. Over the last couple of years, there have been, I would say, new technologies coming that have improved the efficacy of the resynchronization therapy, multipolar pacing. And these algorithms that I'm going to mention here are the SyncAV, CRT. I'm not going to mention the companies, but the technology itself, adaptive CRT, and I'm going to talk also briefly about his bundle pacing. So cardiac resynchronization therapy, it has been demonstrated that reduce mortality and worsening heart failure in patients that have the proper indication. Now, but up to 40% of those patients that have undergone devices implantation, there are no responders. The major causes of no response is, number one, back selection. So we know that by data from the MADIC CRT, that patient with right bundle branch block or interventricular conduction delay that is frequently seen in patients just with large heart or LVH, and patients with very advanced cardiomyopathy, they don't respond. Other causes of no responsiveness is bad or unsuccessful LV lead placement and some programming issues. Sometimes it is very difficult to optimize those patients because there are some dynamic changes in the conduction system that are very difficult to track. And the presence of arrhythmia, especially atrial fibrillation, by the way, decrease the efficacy of resynchronization therapy. So when we look at the responder versus no responders, there is a significant difference in survival, as I can show here in this slide. Cardiovascular events, the same thing, responder versus no responders. So there have been some efforts to try to improve the efficacy of the cardiac resynchronization therapy. One of them efforts have been led to the development of some algorithms that will automatically optimize the device, pacing characteristics for the patient. So one of those is it's called the SyncAV CRT, and the functional optimization algorithm. Basically, what this algorithm does, it measures every 256 cycles, measures the PR interval, and adjusts the PR, the AV delay, to better optimize the patient. And that is because some study has shown that when we fuse the native conduction of the ventricle with the pacing of the biventricular device, we not only shorten the QRS duration, but also improve the remodeling. So they have been, so this is with the aim to do it automatically, so we don't need to bring the patients constantly to do this kind of review, with echoes. First of all, it's a complicated thing, and not everybody does it well, and requires time. So this is a study done with this technology, and what it looks is basically LV remodeling. Surrogates for LV remodeling basically decrease in LV systolic volumes. So this is at 12 months. They compare when you just put the nominal settings, AV delay set up perhaps at 200 milliseconds fixed with biventricular pacing versus this kind of dynamic algorithm. So it is promising in terms of LV remodeling. And these are the two groups, and there was a significant benefit in basically this is just echocardiographic data. Then the other algorithm with a different company is CRT optimization using the adaptive CRT. This is an algorithm that looks for, it adjusts the AV delay and the VV pacing, including LV pacing alone versus biventricular pacing. But this is this one, it does it bit to bit. So optimize the patient automatically to achieve not just shorter the cure duration, but it has shown also the same benefits in LV remodeling. Interesting, with this type of algorithm, there are some data in outcomes. Those patients that have been randomized for automatic optimization versus nominal programming, and in this study showed that it's a significantly decrease of atrial fibrillation 30 days. So this is a conventional CRT versus adaptive CRT. There's almost 50% reduction in the incidence of atrial fibrillation. So these are things that are coming that are promising. This is the analysis with comparing all the demographics. Now I'm going to talk briefly also about His bundle pacing. This is old technology, not done successfully through years, but recently we have some new devices, new leads, and new delivery system that makes it possible. Then when we go back and we analyze data from the David trial that we probably are familiar with, we know that RV pacing alone, it is detrimental and it's increased the risk of heart failure and cardiovascular death. And that's done in a study with a patient with ICDs and pacemakers. Though the results area of the study have been done with permanent His bundle pacing. Most of them initially were done after AV nodal ablation in patients with atrial fibrillation. And across the board, all this study shows a decreased incidence of negative LV remodeling, was development of heart failure, improving in the New York Heart Association functional class, improving in LV function. So there is a lot, those are small studies, but putting it all together, it's also, it have interesting data. These are busy slides and basically say the same. But what I want to specifically, I brought this because they have been also studying patients with cardiac resynchronization therapy. So patients with cardiac resynchronization therapy, when an LV lead in place, and they have been placed in the His bundle pacing, they have been randomized CRT versus His bundle pacing, no significant difference in any outcomes, cardiac remodeling or heart failure. So this is something that we do here, and this is actually one of my patients. This patient have developed cardiomyopathy. It was pacer dependent, developed cardiomyopathy due to chronic RV pacing, have ICD in place, and LV lead failure. So you have this very difficult to access, bad positioning. This is one of the failures this a patient had failed CRT due to suboptimal placement of the LV lead and no improvement in the cardiomyopathy. So they referred the patient to me to see if we can implant the lead in a different place. I couldn't. So there was a very bad coronary sinus anatomy. I placed a pacing lead in the his bundle, and I'll show you. This is the QRS. The patient was pacer dependent, so what I do in those cases, I use a can. I put a CRT can. I connected his bundle pacing lead in the LV port, and I pace from that lead ahead, 80 milliseconds ahead of the RB. I use the RB, the defibrillator lead, as a backup in case the lead dislodge, so the patient won't go to arrest. And that's where you see the second spike. But as you can see here, the QRS is very narrow, and the inverted T waves are called memory T waves. So the patient was pacing out all the time the RB, and I have a physiological left bundle branch block. That's the memory T waves indicated that basically the conduction is completely different. And as you can see, this is basically a normal QRS in a patient with progression LVH. But it is impressive. Now, there are certain things that is not always easy. We don't have the optimal tools to place his bundle pace leads. It is sometimes difficult anatomically to place them. And some limitations, the threshold has a tendency to be high. So many times we successfully implant the leads, but the thresholds are too high that we cannot use it. We have alternatives. We don't need to. This particular patient have almost exclusive his bundle patient, but sometimes the benefit of seen in those patients, even with not a specific his bundle patient, is the same. So those are the take-home points. So automatic and dynamic algorithms for cardiac resynchronization, they seem to be superior to echo optimization and default by B programming in patients with CRT. His bundle pacing, it seems to be superior than set RB pacing and at least equivalent to conventional biventricular pacing in some small studies. There are more studies that needs to be done, especially outcomes data, to validate those findings. And there are still significant limitations for his bundle patient, as I mentioned before, but there is currently, basically, I don't send patients for epicardial placement of the LV lead. So when I have difficulties finding the proper lead location with the conventional way in the coronary sinus, I go ahead and put a lead in the his bundle. Even if it's so selective, I mean, it's not specific for the his bundle catcher, the benefits is great. Outcomes are fantastic. That patient, the picture I showed before, unfortunately I couldn't put the videos here, but it was immediate improvement in the LV function. Patient have like EF around 30%. Next day, an echocardiogram, completely normal LV function. So that I think this is something that we can consider before send the patient for epicardial LV lead placement. So with this, I conclude.